We're at the IAS meeting, and we're here to talk to Sheila and Tom from the University of St. George's. And we really appreciate you taking the time, because we did had the press conference yesterday. And this is a trial on meningitis. And I'm going to let you set it up, the background first, so we know what we're talking about here.
Yeah, sure.
Yeah, sure. So we've just finished a large clinical trial for the treatment of cryptococcal meningitis. And I think a lot of people probably don't know how severe cryptococcal meningitis is and how much of a problem it is in Africa. It's an opportunistic fungal infection, and it affects people with HIV. It's the most common form of meningitis in many parts of Africa, and it kills over 100,000 patients with HIV every year. So that's quite a significant number of HIV-related deaths, 15%. And even though it's kind of a myth that if we roll out ART, this fungal infection will go away. If we treat for HIV, then patients won't get infected with this fungal infection. But that's a myth, and it's not going away anytime soon. So that's why we've conducted this ACTA trial, to try and optimize treatment for cryptococcal meningitis in Africa.
So this is an opportunistic infection. Does it require a certain low number of T cells to happen? Or,
yes, exactly.
So it's seated in your body. It's just waiting for your T cells to drop, much like TB and others.
Exactly. So if you have a low CD4 count, you're much more likely to get
under 200 or under
under 200.
200.
Yeah, that's more common.
Great. And then the trial is
I mean, the difficulty with treatment is, currently the mortality from cryptococcal meningitis is estimated to be around 70% at 3 months. So, that's higher than Ebola virus. And the problem is the current treatment that's available in Africa is called fluconazole, and it is just not rapidly active enough to kill the infection. Whereas the international recommended treatment for cryptococcal meningitis is a combination of 2 other drugs called amphotericin B and flucytosine. But that combination is just not available in Africa currently, and those drugs, particularly the amphotericin, has significant toxicities, which means it needs to be very closely monitored. And
it's a hospital setting.
Yeah, it's a very challenging treatment to give in a low resource setting. So our trial essentially has been trying to define treatments which are much more active than the fluconazole treatment, but will also be feasibly sustainable in lower and middle income countries, unlike the current international standard of amphotericin B and flucytosine given for 2 weeks. That's the international standard. So we tried 2 experimental approaches based on very encouraging smaller phase 2 studies. One was an oral combination of a high dose of the fluconazole plus flucytosine. So that was an optimized oral combination, which obviously in terms of implementation would have huge advantages over this relatively toxic intravenous amphotericin. And the other experimental approach that we tested in the trial was giving the amphotericin, but just for 1 week instead of 2 weeks. And there was quite good evidence that we would get almost all the efficacy with 1 week of treatment, because the drug has a very long half-life and hangs around in the body, particularly probably in the brain tissues where it's needed.
Right.
And you would avoid the toxicity, which normally becomes clinically significant in the 2nd week. So those were the 2 experimental approaches, and as Sheila said, this was the largest trial that's been done to date in meningitis. We enrolled over 700 patients, so we had the power to see whether the new treatments worked. And fortunately, the evidence is that they both did work surprisingly well in some sense. It was particularly 1 week of amphotericin B with the flucytosine accompaniment was associated with 24% mortality. That's in comparison with 70% mortality currently in routine care. So if we could implement that, it would be really a major step forward. And the oral arm also performed relatively well, and at least as good as the international gold standard treatment, but again was much better tolerated with less side effects.
So how do you what's your next step? Is it you need to confirm the results or implement? Or?
Yeah, we really need to implement now, and there's one vital next step, which is access to the flucytosine drug, because currently this drug is not used in any other major infection, and it's currently unavailable in Africa. It's relatively costly, and there simply hasn't been the demand for it up till now. So we are working with international partners to try to make the flucytosine available as quickly as possible to treat this infection in Africa, and that's the first urgent step. And once we have accomplished that, then we can look with our partners to be implementing these trial regimens, and consequently saving tens of thousands of lives per year.
Apart from the humanity of it, like you said, saving the tens of thousands of lives per year, is it more cost effective then, even though it's more expensive?
Well, we are in the process now of doing a formal cost effectiveness analysis, but I mean it's really almost a given that the 1 week treatment will be less costly to implement than the 2 weeks. So in that sense, the new regimes will save lives and save money, and that should help us in terms of implementing them quickly.
So is there some sort of way to recognize this as the standard of care so that you can then get the governments to...
Yes. Well, I mean, the trial, of course, has been ongoing for a number of years. People have been aware of it, the WHO have been aware of it, and there is a plan now to review the WHO guidelines for the treatment of cryptococcal meningitis in the light of our results. And then any other updated evidence, and that's planned, I think, for later. We hope this year. And similarly, other organisations, international organisations, we will obviously be working with them to update guidelines in light of the results.
Is there any specific way that you would see now more of an energy or more of an insistence to try to find out who is positive for cryptococcal meningitis, more certainly because you now have something that's much more effective and can be treated much more easily?
Yeah, for sure. And actually, with using screening programs, you can actually identify patients that are positive for cryptococcal antigen before they develop meningitis. So if you can find those patients before they get severe disease and treat them.
They're carriers, so to speak.
Yeah, it's kind of a delayed onset of disease.
Oh, I see. So
if you can screen them when you find out they're, for instance, HIV positive, if you can screen to see if they're infected.
They're at the same time. I'm glad I asked that question.
Yeah.
So it's really a two-step process.
Absolutely.
Yeah. There's two strands of our effort to try and reduce the mortality and morbidity from this disease. One is treating patients who come to hospital with meningitis, as we've discussed in the trial. The other is this screening and preemptive treatment, which is a strategy that's been expanding now over the last couple of years. And we still got work to do on that to optimize the treatment of the patients who are identified as having cryptococcal antigen. But that absolutely, that's a vital other part in terms of preventing clinical disease. Yeah.
Maybe we can help to get the word out. I don't know, certainly take this video and use it wherever you need to.
That would be wonderful.
Tell the people the good news.
Okay.
Thank you very much.
Thank
I appreciate it. Thank you.
Thank you. Yeah.